I think we can start now. Uh, Good evening, everyone. So, welcome to another episode of Young Family Physicians Forum. Today, our speaker is Dr. GVD Suvimali, a second year registrar in family medicine from the 2022 batch. To introduce everyone to Dr. Suvimali, she is a graduate from Faculty of Medicine, University of Ruhuna, and she did her internship in Teaching Hospital Karapitiya. She has had a wealth of experience as working as an MO blood bank and MO ETU in DGH Mathura previously. And currently, she is attached to the family medicine clinic in West Hospital, Homagama, under supervision of consultant family physician Madam Lalanta Senaratne. So, without further ado, I hand over to Dr. Suimali to start today's case presentation. Over to you, Suimali.
Thank you, Helika, for your kind introduction. Let's
Dr. Dinesh, Dr. Suvimali, you are muted.
Good evening, dear all. This is a case I encountered during my gynecology and obstetric appointment in DTH Mathura. A 26-year-old previously healthy woman, married for 2 years, with third pregnancy, no children, had first trimester miscarriages. Admitted to the gynecology ward at 9 weeks of the POA with the baby bleeding. That was heavy bleeding with the clots and low abdominal pain, but she was hemodynamically stable at that time. She didn't have any long-term illness like diabetic hypertension, hypothyroidism, connective tissue disorders, or arterial or venous thrombosis. No family history of diabetic thyroid disorders or connective tissue disorders. No family history of babies with congenital defects. She has taken rubella vaccine and preconceptional folic acid. Sorry. Okay. The scan TV scan a small amount of retained products and which pass spontaneously. That time diagnosis was the complete miscarriage. The psychological issue that time, both parents were worried about incident. They have fear about that will happen to the next pregnancy or whether they can have a normal child. So at that time, counseling done. The diagnosis was at the recurrent first trimester miscarriages, that are primary miscarriages. And the discharge plan, we plan to review in the gynecology clinic for the TV scan to exclude retained products and to assess her hemoglobin level with the full blood count for further investigation of recurrent early pregnancy loss. In case 2, this is the patient we encountered during this appointment in the BH Homagama. A 36-year-old mother of 2 children complains of the episodic burning sensation throughout the body for the 3 years. Daily symptoms which last about 30 minutes, associated with sweating, irritability, or agitation, and sleep disturbances. That disturbing her day-to-day works, and she didn't have any headaches, no palpitation, no visual disturbance. We suggest to exclude pheochromocytoma, no loss of weight, palpitation or increased frequency of bowel habits, suggest to hyperthyroidism, menstruation normal, 30 days regular cycles, no any long-term diseases or any other. She was not on any medications. Her obstetric history, this is her, she had 5 pregnancies with 2 children. First 2 pregnancies normal, 2 children with age 10 and 7 years. P3 and after that 3 pregnancies were end up with the first trimester miscarriages. That happened 3 years ago. Investigation not done at that time. Counsel as that was the normal thing and possibility of happening to everyone. But since that, she worried about that incidents. She feared about that she's having any sinister pathology. And they are expecting a girl because they are having 2 boys. Then we assess her mental health assessment. We add the GAD score and we put her symptoms into generalized anxiety disorder to score. She has long-term worries about her bad health, not being able to stop or control worries, feeling of nervous and anxious, and episodic burning sensation of body with sweating. So that score is 4. And during last 3 years, she's suffering from these symptoms. So generalized anxiety disorder associated with the panic attacks. We think so. And then that predisposed with the recurrent first trimester miscarriages and the precipitate with the secondaries of fertility. And she worried about that, and she was taken treatment from the Ayurvedic hospital. They treated continuously 6 months for whether they said she's having a serious illness, and so she need long-term treatment. They said that. So she's too much worry about that. Perpetuate factors, she has poor family support with the poor income, and they are expecting a baby. All these predispose and these factors contribute to this presentation. With these 2 case scenarios, we talk about the miscarriages. What do you mean by miscarriages? Royal College of Obstetric and Gynecology's definition, miscarriages, the new definition in 2023, spontaneous loss of pregnancy before the fetus reached the viability, the period between time of conception to 24 weeks of period of amenorrhea. The recurrent miscarriages, they define as 3 or more consecutive pregnancy losses before 24 weeks of pregnancy. But now they encourage to evaluate after second miscarriage if suspecting pathological causes. In American Society of Reproductive Medicine definition, they say 2 or more miscarriages before 24 weeks of the POA. Let's talk something about the epidemiology. The incidence of miscarriages, 10 to 20% of pregnancies. 5% experience 2 or more losses, and 1 will experience 3 or more losses. But true number may be increased because unrecognized pregnancy loss, some pregnancies end up at the before clinically diagnosed or clinically or biochemically diagnosed because of the defect in the fertilized or gametes. That they think as this is a menstruation, but these miscarriages are not counted. Incidence of recurrent miscarriages, 1% of the first trimester miscarriages among clinically recognized pregnancies, and 1 to 2 second trimester recurrent pregnancies. Second miscarriage is 15% after the first miscarriage, and the third pregnancy loss is 30%. Let's talk about some miscarriages we can categorize as natural, the artificial, natural is isolated or recurrent miscarriages, threatened, inevitable, complete or incomplete, and the septic. And artificial in the criminal law, justifiable. What are the types of the recurrent pregnancy losses? The primary recurrent pregnancy loss is a person who have never given birth to the live baby. In the first case we discuss here. The secondary recurrent pregnancy loss, woman who has previously given birth to live baby. The second case. Then first trimester recurrent pregnancy loss before 12 weeks of POA. Second trimester means between 13 to 24 weeks. When pathophysiology of the miscarriages, defective placentation and pathophysiology depend on the cause of the miscarriages. But in mainly defective presentation and microthrombi in the placental vasculature cause cut off blood supply to the fetus. These mechanisms, the immunological rejections or apoptosis, inflammation, or excessive oxidative stress can cause recurrent miscarriages. Why miscarriages happen? Or what are the causes for the miscarriages? If we categorize these as the first or second trimester miscarriages, most of the first trimester miscarriages and all of the miscarriages in the most common is the genetic causes. It's a 50% causes due to miscarriages due to genetic causes. And endocrine causes, immunological means autoimmune or alloimmune causes, hematological, mainly first trimester miscarriages. Causes of the second trimester, anatomical causes or infectious causes. Even though we categorize it the first and second, but any time this can happen. Pie chart. Antiphospholipid, so fetal aneuploidy. This number, chromosomal number defect. 41% due to the fetal aneuploidy, and the chromosomal abnormality of the either partner in the 10%. The OSA including the genetic causes, and the antiphospholipid syndrome and the antibody syndrome, antibody the 9%, and the uterine anomaly in 5%, and endocrine abnormality 6%, and the unexplained 25%. Then when should we investigate for the miscarriages and recurrent miscarriage? In 3 or more first trimester miscarriage or 1 or more second trimester miscarriages. Then when we look for the causes of the recurrent miscarriages, first genetic causes for the recurrent miscarriages. This is the commonest cause. This increased miscarriages 20 to 30% or up to 50%. This figure include only aneuploids, that means number of chromosome abnormalities causes, because can only test for that easily test. It does not include Mendelian disorders, so the mutation at the several loci. Genetic causes can divide into parent factors or the fetal factors. Parents factors, the chromosomal abnormalities. Chromosomal abnormalities mainly numerical or structural abnormalities. Fetus factors, chromosomal abnormalities or single gene defects. Chromosomal abnormalities, structural or numerical abnormalities. The structural abnormalities, translocation, mainly due to translocation. Translocation is two types, reciprocal translocation and the Robertsonian translocation. And the numerical abnormalities as a non-disjunction. Translocation and the structural chromosomal abnormality. And then in the reciprocal translocation, the chromosomes of two parts divide and the switch break and attach to the another. No chromosomal part losing. They are only balanced and unbalanced translocations. If balanced translocation, the phenotypically normal people, but complications in the recurrent pregnancy loss and infertility. If unbalanced translocation occur, abnormal children. In the Robertsonian translocation, balance that also balance and unbalance. And there, the chromosome is small part of the chromosome break at the centrosome, and large two parts bind together and make one chromosome. That chromosome can contain different chromosomes. Here the example is 14 and the 21 is translocation. One chromosome can contain two chromosomes, and 21 and the 40. The normal child that is balanced translocation of a normal child or balanced carrier, unbalanced the downs. Here we can understand easily. This is the possibility of the parent's chromosome with the balanced translocated chromosome. They can a possibility of the meiosis gametes. 6 type of gametes can fertile with the normal gamete. Here, then the possibility of the normal zygotes and the balanced carrier. Others are trisomy 14, monosomy 21, and the trisomy 21. This trisomy 21 viable, others are not viable. They will abort. And this normal baby and the balanced carrier is a phenotypically normal child. This is Robertsonian translocation. Incidence is 1 in 1,000. If you remember this photo, this is one of our OSCE case. Here the Robertsonian translocation in the 21 chromosome. Here only one single chromosome, but here other part attached to the 14 chromosome. The balanced translocation is balanced carrier. More about the balanced translocation. 1 in 560 people have balanced translocation. Commonest genetic cause of parents for recurrent pregnancy loss. Risk of miscarriage 20 to 30% or 50%. One piece of chromosome attached to another, bit of chromosome from the different part, not genetic material is lost. Chromosome section are simply joined at the wrong position. Number of chromosome is correct. Can be inherited or new mutations of fetus. Most individuals with balanced translocation have normal phenotypes. They are undiagnosed until they suffered low recurrent pregnancy loss. Either male or female partner has a balanced translocation. Here the non-disjunction, normal and meiotic division here the failure of the separation of the chromosomes and 3 chromosomes in the two in the one cell and they fertile with the normal cell and make a trisomy. This is a Down syndrome. When we investigate first pregnancy loss or second pregnancy loss, here we in the RCOG guideline we have to wait until the third pregnancy loss. The chromosome analysis of the product of conception we can arrange. The product of conception, the analysis may aneuploids. That means the number increased number. No further investigations that due to the fetal defects in the meiosis. Is the unbalanced chromosome translocation or inversion, parental karyotyping, that is unbalanced balanced translocation, unbalanced translocation. So we have to look for the parents karyotyping. If the euploids, the number is okay, we have to look for the other causes for the recurrent pregnancy loss. When investigating genetic causes of recurrent pregnancy loss, karyotype of the product of conception or karyotype of the both parents. The karyotype of the both parents, we can arrange it at our primary care setting. There's no hospital labs not doing that karyotyping, but Center for the Genetics and Genomic Faculty of Medicine, University of Colombo, they are doing that genetic test. The 10,000 for each parent. So we can arrange. That is not too much when comparing the other investigations. We can contact and get appointment. send the patient with request with the both parents, karyotyping of the both parents. Other test is the fluorescence in situ hybridization. That is very expensive. We can assess the single gene mutation or mutation at several points. I would like to tell you we can arrange this at our primary care and to help the people with the recurrent miscarriages. Management, offer genetic counseling, discuss the risk of the future pregnancies, the probability of the healthy child and the carrier child and the sick and the abortions we have to discuss with the parents. Then the possibilities and what are the other alternatives are available. The other IVF by using the donor gametes. If the defect is one of the parents' defect, we can use the donor gametes or IVF peri-implantation genetic diagnosis that is doing nowadays, but very costly. If the gamete is unhealthy or with the chromosomal abnormalities, not implanted. Trial of next pregnancies, without doing anything, we can have a trial whether it's a healthy baby or carrier or the miscarriages. With the discussing after those, we let them to decide what they want. Immunological causes for pregnancy loss. There's an autoimmune causes and the alloimmune causes. Autoimmune antiphospholipid antibody syndrome, SLE, antinuclear antibody or antithyroid antibodies. Alloimmune human leukocyte antigen sharing rhesus antibody. The mainly we here discuss about the antiphospholipid antibody syndrome, because it is very common. It's a multisystemic autoimmune hypercoagulable state caused by the antiphospholipid antibody. Account for 10 to 20% of recurrent pregnancy loss, arterial or venous thrombus formation and pregnancy losses. 3 antibody that can identify in the antiphospholipid syndrome. What are they? Lupus anticoagulant, anticardiolipin antibody, anti-beta-2 glycoprotein 1. How we diagnose antiphospholipid syndrome? Updated ICR criteria 2023, American College of Rheumatologists, at least one positive antiphospholipid antibody test within 3 years of an antiphospholipid syndrome associated clinical criterion. And additional weighted criteria with the score range 1 to 7 points. Additional criteria are the 6 clinical domains and the 2 laboratory domains. My clinicals are the macrovascular venous thromboembolism, macrovascular arterial thromboembolism, thrombosis, microvascular, obstructive, cardiac valve. One is missing. 2 laboratory domains are the lupus anticoagulant test, anticardiolipin or the beta-2 glycoprotein. 3 points each from clinical and laboratory domains. Diagnose. But up to now, here the criteria, the diagnosis criteria, at least one clinical criteria and the 1 laboratory criteria they use. Clinical criteria, 1 or more confirmed vascular thrombosis. And the pregnancy complications, 3 or more unexplained consecutive miscarriages, less than 10 weeks of POA, 1 or more unexplained deaths, more than 10 weeks of POA of the morphologically normal fetus, 1 or more premature births, less than 34 weeks of POA due to the placental insufficiency or preeclampsia. Laboratory criteria, as previously mentioned, the 3 antibody test. They mentioned that they repeat test at least 2 or more occasions and at least 12 weeks apart. The risk factors assigned for the female 30 to 40 year age group have other autoimmune diseases and feminist antiphospholipid syndrome. The triggers are the infection, surgery or trauma, malignancy, anticoagulant withdrawals, pregnancy or initiation of OCP, a flare of autoimmune diseases, drugs like chlorpheniramine, procainamides, phenytoin, or clonidine. The clinical presentations, the isolated or recurrent thrombosis is the presentation. The arterial venous thrombosis, mainly DVT. The DVT and the increased risk of pulmonary embolism then end up with the pulmonary hypertension. Hematologically, and from the full blood count, we can diagnose the thrombocytopenia, hemolytic anemia. That the most dangerous and the emergency complication is the ocular retinal arterial or venous thrombosis. And others are the skin manifestation, pulmonaris, purpura, infarct, ulcerations, cutaneous necrosis, digital gangrene, or leg ulcers, and the renal thrombotic microangiopathy and nephropathy end up with the renal failure. Peripheral neuropathy and adrenal infarction, hemorrhages, and adrenal insufficiency. Obstetric condition associated with antiphospholipid syndrome and the recurrent pregnancy loss, preeclampsia, IUGR, preterm deliveries, and IUD. Here the implantation, the placental implantation, the spiral artery is embedded into the uterine bed. Here with the antiphospholipid antibodies, they react with the they arrest the implantation of the spiral arteries. That will the pathology of the cause associated with the antiphospholipid syndrome. Other thing is the antiphospholipid antibody production of the clots, blood clots, and that cut off the blood supply to the fetus. Other causes other than the antiphospholipid syndrome, antiphospholipid antibody present in the autoimmune diseases like rheumatoid arthritis, SLE, and MS, and the pregnancy, 2% pregnancy apparently healthy women, 20% apparently healthy women with recurrent pregnancy loss, and the stroke, and patient stroke, and the DVT. Management when the primary prevention with the low dose of aspirin, we can use the patient with the high risk of antiphospholipid syndrome and antiphospholipid antibody profile, but no history of thrombosis. Patient with SLE with the high risk of antiphospholipid antibody profile and the low risk of even low risk of antiphospholipid profile, they may be recommended. Non-pregnant women with the obstetric antiphospholipid syndrome, we can start aspirin for the primary prevention. The secondary prevention, venous thrombosis. The warfarin target is INR 2 to 3. Long-term anticoagulant to prevent recurrent thrombosis. That unblocked DVT or venous thrombosis, 40% risk of recurrent thrombosis if not on anticoagulant. But even though they are taking anticoagulant, 22% risk of recurrent thrombosis. Lifelong anticoagulant recommendation for unprovoked thrombosis. Direct oral anticoagulants, if single or double antibody positive, we can use if warfarin intolerance, start direct oral anticoagulants. In the arterial thrombosis, warfarin preferred over direct antioral coagulants. INR goal 2 to 3 or more than 3. Low molecular weight heparin, if warfarin can't tolerate. Recurrent thrombosis, warfarin plus aspirin or change into low molecular weight heparin. INR, we have to keep INR more than 3. Triple positivity, all the 3 antibodies are positive, warfarin is superior than the DOAC. During the pregnancy, pregnant female with in the guideline they said on the first pregnancy no recurrent no treatment indication. But in a single pregnancy loss less than 10 weeks of POA, no treatment indicated. High risk antiphosphate antibody without pregnancy complications and thrombosis, low dose aspirin. History of 3 or more pregnancy losses less than 10 weeks of POA or more than 10 weeks of POA. Aspirin should start before the pregnancy. Start low molecular weight heparin as early as possible, ideally 6 weeks of POA. If a woman on warfarin, convert into the low molecular weight heparin. During the pregnancy, aspirin, low molecular weight or unfractional heparin throughout the pregnancy. The success rate is the 75%, the good outcome. The history of delivery prior to 30 weeks or eclampsia, pre-eclampsia or other features of placental insufficiency, low dose aspirin or low dose aspirin plus prophylactic low molecular weight heparin, or do not recommended during pregnancy because of lack of evidence or safe data. Then low molecular weight heparin, the subcutaneous enoxaparin we use frequently, preferred over unfractional heparin because better bioavailability, longer half-life, convenient once daily dosing, low risk of thrombocytopenia and osteoporosis. Patient can inject in the home. We practice during the clinic and they can inject during the home. That's very easy for them. The obstetric antiphospholipid syndrome with recurrent pregnancy complications. If the aspirin and we increase the heparin dose, if not responding, we can add hydroxychloroquine or low dose prednisolone or IV immunoglobulin or rituximab. Then anticoagulant can assume 6 to 12 hours after cesarean section and 4 to 6 hours after the normal vaginal delivery. Warfarin or heparin not contraindicated during lactation and then during follow-up. Continue anticoagulants at least 6 weeks because postpartum high risk of thrombosis, or continue pre-pregnant dose of warfarin and aspirin. Then there's SLE, that was autoimmune disease, prevalence 1 in 3,000 female to male 91, multi-system involvement with mainly skin, joint, lungs, kidney. Most common disease associated with antiphospholipid syndrome. If the SLE associated with the ACL antibodies and 20 to 30% has SLE associated with ACL antibodies, and the 15 to 34% has LAC antibodies. SLE and antiphospholipid antibody increase rate of miscarriages and late pregnancy losses, increase fetal death, and second and third trimester associated with fetal death in the second and third trimester. Other autoimmune disease conditions is antinuclear antibody, but can in normal pregnancy also antinuclear antibody test can be positive. So that test is not recommended. Antithyroid antibody also, thyroid specific autoantibody, antithyroid globulin and the antithyroid peroxidase. Women with positive antibody test, no clinical evidence of thyroid disease or thyroid hormone. The treatment that also same as the antiphospholipid syndrome, subcutaneous heparin, low dose aspirin, steroid, immunoglobulin, or combine of these therapies. The alloimmune abnormalities is maternal immune response to antigen or placenta or fetal issues, rhesus cell immunization or HLV sharing. The other causes for the recurrent pregnancy loss is the hematological defects. Most of the hematological defects are the clotting defects and the bleeding. Hematological changes and pregnancy, the normal pregnancy also increase the hypercoagulable state, defective presentation and microthrombi in the placental vasculature. Activated protein C resistant factor V ligand inactivated by the activated protein C. Patient with factor V ligand, this is resistant to inactivated by the activated protein C, increased thrombosis and the hypercoagulable state, and the familial thrombophilia. Other the coagulation defects with the deficiency of antithrombin 3 protein SOC, specific coagulation factor defect factor 12, and the abnormal homocysteine metabolism that may be congenital or acquired, associated with thrombosis and premature vascular diseases. Then the infectious causes. Common cause of pregnancy loss in second trimester. Torch infection is toxoplasmosis, rubella, cytomegalovirus, HIV, listeria, chlamydia, bacterial vaginosis, parvovirus, trypanomatosis, Lyme disease, or malaria. When in the infective foci for those infections, direct infection of the uterus, placenta, or fetus, and the placental insufficiency, chronic endometriosis, and endocervicitis, amnionitis, or infected IUCD. How we investigate and manage the screening for infection? We can arrange this in our primary care, the blood sample and culture for the infective to exclude the infections, high vaginal swabs, endocervical swabs, send sample to STD, microbiology or parasitory and MRI for investigations, and manage according to the specific cause. Some environmental factors also cause for the recurrent pregnancy loss, isotretinoin, anesthetic gases, tobacco, alcohol, caffeine. Manage, encourage lifestyle modification and counseling for prevent from exposure. Then we look for the anatomical causes. They associate with the second trimester pregnancy loss and preterm deliveries. The causes: uterine Mullerian anomalies, septate uterus, uniconjugated to biconjugated uterus, dihydroethylbisterol exposure related anomalies. Others are Asherman syndrome, incompetent cervix, leiomyoma, uterine and cervical polyps. How we investigate for the anatomical causes? Most of the we can nowadays all the pregnancies are screened with the ultrasound scan, so we can identify it during the pregnancy also. If not identify, we can arrange ultrasound abdomen, TV scan and ultrasound abdomen, or the hysteroscopy, sonohysterogram or HCG, or if not found, MRI, the uniconjugate uterus, the banana-shaped cavity with the single fallopian tube. Management: prophylactic cervical cerclage and the correction surgeries. Cervical cerclage, usually we do it in the 13 weeks of the pregnancy because we think most of the genetic causes for the recurrent pregnancy loss in the first trimester. So we don't keep the chromosomal abnormal babies inside. So we postpone the cervical cerclage until 13 weeks of the POA. Maternal and paternal age. The age is increased with the maternal age, increased risk of miscarriages. If the father's age more than 40, increased risk of miscarriages due to the increased risk of chromosomal defects. The relationship with the maternal age and the miscarriages, the under 35 years, the 15%, and the with the near 35 to 39, 25, 40 to 44, 51, and over the 45, and then 90%, more than 90%. with the age, most of due to the non-disjunction. What are the endocrine causes? The ovulation, implantation, and early stages of the pregnancy depend on the intact maternal endocrine regulatory system. Endocrine disorders, thyroid, that are very common in the thyroid and the diabetes, and at the low level of progesterone, luteal phase defects, PCOS, hyperprolactinemia. Thyroid dysfunction, well-controlled thyroid disease does not cause miscarriages. High-level TSH, thyroid antibodies, increase risk of miscarriages. And the immune dysfunction caused by thyroid conditions can impair maternal tolerance to the fetus. And high thyroid releasing hormone increase prolactin secretion which inhibit FSH and LH. High level of prolactin affect the function of ovaries. So luteal phase defects cause for the miscarriage. And the hormone imbalance cause impair endothelial proliferation, problem with the implantation, cause pregnancy loss. And the prolactin imbalance due to the prolactin secretory tumor or hypothyroidism. And the diabetes in the 2 to 3-fold increased risk of miscarriages and fetal abnormalities. Well-controlled diabetes not increase the risk of pregnancy loss and the malformation. Insulin resistance can increase risk of hyperhomocystinemia, interfere with the endometrial blood flow, and also lead to increased expression of plasminogen activation inhibitor 1, then increase the thrombosis. But in the literature, they have not clearly defined what are the pathology of the diabetic and the recurrent miscarriages. And the PCOS, they also the insulin resistance and the resulting in the hyperinsulinemia play major role. Hormonal imbalance may be caused low progesterone or high insulin and the testosterone. The insulin resistant, as previously mentioned, the diabetic and the same as in the diabetic, and the other low progesterone and the high testosterone can maybe the hormone that can cause the recurrent miscarriages. Manage early pregnancy with the oral low IM progesterone, but no evidence whether it's good or bad. The luteal phase defects, so the same as previous. Progesterone is the hormone differentiate and proliferate to endometrium to secretory reproductive to embryo implantation, receptive to embryo implantation. Placental trophoblasts start to support after 7 weeks of the pregnancy. Up to that, corpus luteum supply progesterone. If corpus luteum removed before 7 weeks, the progesterone reduce, so increased rate of miscarriages because of failure of the implantation. We can investigate our patients at our primary care level, assess the progesterone level at 21 days, and manage early treatment with the progesterone, and the early referral is the important. That the investigation we already discussed for the endocrine disorders, TSH, thyroid function assessment, and the thyroid peroxidase antibody, antithyroid antibody, and then for the diabetic investigations, and the progesterone test, day 21 progesterone level or serum prolactin level for the hyperprolactinemia. All the things we can arrange in our primary care. The sperm factors, abnormal DNA in the sperm may be higher possibility of miscarriages. Increased risk after 40 years of age, but no good evidence to change sperm health. So no need to, even though we test, no point to testing because of no, we can't change the quality of the sperm. Next, we discuss the long list of the causes of the recurrent miscarriages to get the idea how we manage how we identify in our primary care. All of the cases we can identify in our primary care. Then we look for the complications of the miscarriages. The acute complications most of the time during in the hospital admission, bleeding leading to hypovolemic shock, infection, septic shock, medication, and the prostaglandin analogs increase the pain and the risk of the pulmonary embolism, and the surgical anesthetic and complication procedure during procedure, uterine perforation, and the long-term adhesions. That also cause for the secondary subfertility also. And the bereavements and the grief. Nobody talk about that part. And in the miscarriage is a profound emotional impact on woman and the partner, family and the friends. Unlike in other losses, no funerals or other rituals to gather with loved one to share their emotions. Bereaved couple person move through phases until recovery as other losses. But we also have to understand this also the process of the normal uh, loss. The mind and the psychological, the emotional impacts same as the other losses. The psychological impact, the single miscarriage was very distressing. It can be heartbreaking if next pregnancy is affecting too. Each new pregnancy brings both hope and anxiety. Psychologically stress, anxiety, depression, grief, anger, worries, seeking reasons, guilt and blame as our second case. The long-term relationship and intimacy problems, loneliness, jealousy. When we look at the babies playing with their parents and the newborns and the pregnant ladies, they have jealousy and they avoid that situations. The mental health problems in long term, generalized anxiety disorder like our patient, and the depression, post-traumatic stress syndrome, and the social stigmata. It's not a stigma, but cultural and social attitude towards the affected women or couple. There's a negative association in the Asian countries. Most of time that negative association, most of time they think as a fault in the female. Then so a lot of problems for the female. But major impact on affected woman and couple also. That emotional in fact, the WHO also mentioned that the unacceptable stigmata and shame women face after baby loss must end. The pregnancy must be a positive experience for mother and baby. When this isn't possible, women deserve our empathy, respect, and support. The management of psychological issue in the primary care, how we manage the psychologically. They assess the mental status, both women and the partner. The research said that 72% women and 66 men were affected from anxiety after the recurrent pregnancy loss. 51% women and the 19% men affected from depression. How do we manage at our setting? The counseling. We can arrange psychotherapy, supportive group therapy, sharing experience with others, and if they need, we can add drugs. And the next pregnancy, allow time and space to grieve, process and heal following recurrent pregnancy loss, and until investigations are complete. And the lifestyle modification that was common as all the other patients, healthy, balanced diet, maintain healthy weight, exercise, stress reduction, mainly focus on the stress reduction, and they stop alcohol, smoking, or too much caffeine. Frequent and regular follow-up to monitoring and assessment of progress of identify underlying causes or diseases and emotional health, which cause for the recurrent pregnancy loss. The pre-pregnancy counseling then, when we psychologically and mentally and physically stable for the pregnancy, we should arrange pre-pregnancy counseling, optimize the comorbidities, daily folic acid to 5 milligram, convert the drugs into the non-teratogenic drugs. Example, glycemic control with the metformin or insulin, antihypertensive calcium channel blockers, warfarin converted into heparin. The assessment of the new pregnancy with early ultrasound scan and hormone assessment. During early identifications is important to manage early pregnancy losses. And coordinated care, early referral to the VOG, endocrinologist, rheumatologist or hematologist. Prognosis and future considerations. Success rate depend on the underlying cause. Many women go on to have successful pregnancies. Investigations and help them to achieve their dreams. Continue review with the new articles, researchers, ongoing studies to further understand the causes and development new treatment. The conclusion and the take-home message is the recurrent pregnancy loss is psychological issue for most of couples. It is a neglected zone, so should investigated. Recurrent miscarriage is a multifactorial issue requiring a multidisciplinary approach. Important on personalized management, patient-centered care based on the individual's diagnosis and needs. Primary care is a first place where we can identify the causes and arrange necessary investigations, management, and shared care. This is a reference, RCOG Green Top 17 guidelines in the 2023 Medscape e-medicine article and the National Library Medicine article. Here the links are also there. And ACR guidelines for the antiphospholipid syndrome. That's the end of my presentation. I would like to thank Dr. Lalanta Senaratna, consultant family physician, for her lovely guidance and the correct guidance and all the things she has done for me. And thank you all the colleagues. And I think it's maybe boring, no interruptions, no questions. If you have any questions, this is time for discussion. Thank you all.
Thank you, Dr. Suvimali, for that very informative presentation. Just one question. Like in a normal pregnancy, where we recommend an interval of 2 years, is there a recommendation for a miscarriage for the next pregnancy, recommended interval?
No, usually not recommend no interval. If the patient normally with the start with the menstruation, we can she can go for the another pregnancy. But in here, if she is having some problem with the health problem we identify or mental problem, we have to wait for some time to recover from these problems. And during recurrent miscarriages, we have to identify what are the causes. So we have to wait for until that. Otherwise, after the first miscarriage, we don't recommend. We don't ask to wait. That's with the next regular cycle. They can try. Only folic acid will be given.
Thank you, Dr.
Any more questions?
Yeah, the thing is now anyway, so the best thing is with all the information, it's a very sort of a very comprehensive, informative presentation, but you managed to finish exactly 1 hour. So because it could be maybe there are no any disruption, any interruptions or whatever the things. Anyway, so it's a very sort of complete, I must say, I mean, you touch each and every part. causes and how it happens, and after the delivery, what is your responsibility, investigations, is a huge section. I think if you have this, this in a nutshell of everything, if you have this knowledge, you can actually manage a patient where you begin. When you see a patient at your clinic, or the patient, he has a case, for the long case, or usually we do not give this type of patients for the OS case, maybe a long case, or some sort of essay questions. So that is how a part, of course, we took for I think, screening, for your screening, your Suvimali's batch. That's how we check your knowledge, whether you are able to do the job in primary care level. So it's a very comprehensive one. So that's why I think the people, they don't have questions, but I think by listening will not help. You should maybe like read, or like you to listen. It will be available in the YouTube then. And you must have some sort of your own sort of set of questions, and the way you investigate in each and every patient with recurrent miscarriages. That means, but here, of course, the particular patient, even she doesn't know, but nobody like talk about worries. Who is disturbing this? Just check. I don't like these things. Just check who is the person who is disturbing. Anyways. Right. Now, because if you can do this thing at the exam or at the clinical setting, that is the only thing we expect. Anybody, you cannot, because that even this particular second patient, nobody, of course, talk about. Mainly, they don't talk about the particular person's psychology, what happened to the patient, the anxiety part. Nobody detects. So that is, of course, it's a part of your story. We cannot expect the secondary or the tertiary care people do that job. So they are very focused to their management plan. Because of that, it is your duty. Once the patient gets this type of a thing, ultimately you have to sort of do some good consultation, interviewing, and try to find out the sort of their psychology, their other social issues, everything. And if you don't do that job, so the patients will end up with this kind of presentation, because the way we look at the problem is very comprehensive. That's why we were able to catch the issue. Otherwise, we missed that also. Now she feels very sort of she's comfortable, because we actually talk about the real reason for encounter. So there are a lot of things to you to understand. So you better read this thing, or better listen this thing. The huge thing, she touched a very huge sort of a section of all the things, the endocrinology, the rheumatology part, as well as the gynecology part, huge section, and the psychology part, huge section. So you should read, and you may add things according to your wish. And I think that is the idea of doing this type of presentations. This is sort of what we call as young family physicians forum. Yeah. So you should show who are you. One day you are maybe not young, and you will be the consultants or very senior consultants in the field, and you should show who you are. So I think with that, I stop my words. If you have any concerns and you want to add things, this is a forum to you to talk. This is not my time. It is your time. I am there for you to sort of give some guidance. How do you do this job? Okay, thanks, Suvimali, for your nice presentation.
Thank you very much again, Dr. Suvimali, and thank you, madam, for your kind input. In the absence of questions, I think we can wrap up today. So This concludes another episode of Young Family Physicians Forum. Hope to meet you all again in another 2 weeks duration. Till then, wish you all good night.
Good night then. Good
Good
night.
night, and thank you.